Well, I am thrilled to be here, and this is such an exciting thing. And I see my collaborators for these last, it's been almost 20 years all around, and all the different students we've worked together with. And Ellen Loy is here from the House of Ruth, Maryland, which is a wonderful collaborator with many of our endeavors. So all I need is a mouse. There we go. And as has been said, I'm from the School of Nursing, thanks to Dr. Coker, my friend, in terms of shouting out the work we've been doing for many, many years. And she's been right there parallel with me. And what we're working on and thinking about, and in terms of what research needs to come from now, was based on the clinic-based screening, the IOM recommendations in 2011 for women's health. And the recommendation that's near and dear to our heart is that 5.7, screening and counseling for interpersonal and domestic violence. Screening and counseling involve elicitation of information from women and adolescents, and that's an important piece of this, and we're going to hear from Liz a bit about that, about current and past violence and abuse in a culturally sensitive and supportive manner. I was just talking to Courtney about her provider never looking up from the screen while she asked about domestic violence, because now we have screens between us and our providers. And so, you know, there's good things about electronic medical records, and there's problems. But in a culturally sensitive is a piece that we haven't worked as hard on as we need to, and supportive manner to address current health concerns about safety and other current or future health problems. The entire report is on the IOM website. Less than 2 weeks later, and I loved Shannon's presentation in terms of policy. This was a very tightly orchestrated policy initiative. There were a lot of people working behind the scenes before the committee came out with its report. We didn't know exactly what it was going to say, but we knew there was people like Linda Rosenstock and particularly Carol Weissman that were on that committee. And so we had somewhat of an idea, and when I say we, it's a bunch of us that work together. We had somewhat of an idea what it might say, and we needed to be all ready to get this into the implementation phase. So less than 2 weeks later, HHS adopted the IOM's recommendation. Secretary Sibilia said that services for women, these services for women that were rolled out in that IOM report, were to be included in the implementation of the Affordable Health Care Act. And so preventive services for women, including annual well woman visits, screening for gestational diabetes, breastfeeding, et cetera, and so forth, and again, highlighted screening and counseling for interpersonal and domestic violence. To be covered by new health plans, and these are the new health plans that are being rolled out as part of the Affordable Health Care Act, without cost sharing. Now, of course, what immediately got highlighted and controversial was the one about contraception, which was good and bad because it diverted any attention that might have been unwarranted toward interpersonal and domestic violence. And you know what all happened and all of that. So the new health plans are required to comply with these guidelines for policies with plan years beginning on or after August 1st to 2012. Now, it's anticipated, you know, depending somewhat on Supreme Court decisions and et cetera, that existing health plans will be rolled into these new insurance packages under the Affordable Health Care Act somewhere along the line during 2012 and during implementation. So it has to be happening in new health plans. Now, those of you that are keeping track of implementation of the Affordable Health Care Act, you know there's a lot of plans, existing plans that are turning themselves into new plans in order to comply with this. There's a lot of activity going on. So it will be a lot of insurance plans. So the Secretary Sebelius tasked the DHHS Office of Women's Health with the implementation. There already were several intergovernmental task forces on dating violence, violence against women, sexual assault. I think a couple of the members of some of those task forces are actually here. And they have been working hard around a number of initiatives around violence against women, but now are working particularly on this issue also. In December 2011, there was a conference on the implementation. Those of us that were there were able to really stress the importance of research happening with this. Bridget was another person that was there and very influential at that conference. And especially on this formulating and testing, what is this brief counseling going to look like? That providers are supposed to be providing. Now, if you have a social work department on call 24 hours a day that you can, that could be your provider, maybe. But providers are supposed to be providing this brief counseling. And that's what we don't really know, what that's going to look like, and we haven't really tested what that might look like. And then making sure it's culturally sensitive and supportive would be the other thing that I think there needs to be development on. So we presented what's known about screening and talked about some of it. One of the things that's been done in research conducted here, and I thought I saw Deb Troutman back there at one point in time, but Deb Troutman and her team tested a computerized screening for domestic violence, found far higher rates of disclosure. Women trust computers more than they trust us, apparently. I think it's also, it takes away the issue of asking badly. A computer doesn't ask you badly. And it also, when we've found this in our studies, really seems to set up this dynamic that women disclose to the computer all kinds of things that they might not say out loud. It takes away some of the stigma kinds of notions. I'm afraid if I disclose this to this provider, they're going to think worse of me, etc. The what to screen with, and Ann talked about that. The screening that does no harm, we talked about that this morning. And women want to be screened. Important research that Andrea Geelan has done and some of our teams in terms of asking women in a variety of healthcare settings, emergency departments, primary care, and also population-based studies, women saying, yes, I want to be asked, both abused women and not abused women, I would not be offended, et cetera, and so forth. Some of the things that our provider organizations worry about. So in moving forward, first of all, the Coordinating Committee on Women's Health and DHHS violence-related committees, those different intragovernmental committees, have been tasked on working on this implementation. And there's definitely a recognition amongst them that public-private partnerships are going to be required with health associations, with healthcare providers and healthcare provider associations. Domestic violence advocacy organizations will be critical in this, and they plan to work with experts on healthcare and domestic violence. Some of the implementation activities, and this is sort of a preview, it's not been officially released yet, but will be soon. Dissemination plan that will come through DHHS, fact sheets for providers, and to promote more education around screening. The topic of screening in the DHHS Office of Women's Health activities around domestic violence more officially. They have a really good website with lots of materials that will be updated and focused very much on screening, I suspect. Part of the partnership and outreach will be multi-sector outreach strategies, building relationships with professional and health associations through meetings and collaborations. I think all of the different professional meetings this fall will probably have sessions on screening, various parts of screening. A broader partnership and outreach to focus on the particular stakeholder groups that we know are very much affected by this, disability issues, LGBTQ populations, Medicaid, minority health, and women with histories of trauma. So we know oftentimes that when women come to us and say, yes, I'm being abused by this current partner, they also have a long history of various kinds of trauma, which contributes to a lot of their healthcare problems. and advocacy groups will be part of it. There will be training. There's going to be a toolkit development, and they're working with Futures Without Violence on this, and Futures Without Violence has put together a great interdisciplinary team of experts to review a lot of those materials. Online resources, I should say conflict of interest. I'm chair of the board of Futures Without Violence in case, anyway, in case you think I'm promoting their stuff, I do. Online resources, both in Office of Women's Health and at Futures. Futures is funded as the DHHS National Health Resource Center. Online resources will include tip sheets, training videos, fact sheets on state laws. A lot of that has already started to be developed. A lot of it you can find already. Liz Miller has worked really hard on some of the reproductive coercion materials with them. Screening tips for various health settings. Getting feedback from providers to ensure outreach to various populations. All of the notions of inclusivity and accessibility people are really trying to think about. Opportunities to link screening for current and recent domestic violence with assessment for lifetime trauma, as I mentioned. And there will be some webinars available, general webinars, DV screening and trauma assessments. They will be targeted to different provider groups, et cetera. And importantly, research. And there's, as I mentioned, recognition for needed research. It was interesting because we mentioned at that conference, Nancy Glass's IRIS online intervention. And they're like, so when do we have efficacy data for that? We need it by August 1st, 2012. And Nancy, we're like, not quite have it. But they love the idea. And, you know, the feds are anxious for research to be completed tomorrow. But they do recognize that there needs to be a long-term research plan, and there's a potential for a research workshop or summit next fiscal year 13, probably happen before the end of December, knowing what's going on. NIH will obviously be a key player there. We're gracious to have somebody from NIDA here. NICHD and NIDA, NIAAA are the within NIH, along with the Office of Women's Health Research and the National Institute for Minority Health and Health Disparities, that all consider violence against women to be one of their priority areas. AHRQ is another possible funding source for this research, and CDC. And then there's the electronic health records. And there's recognition of its importance in the health field and to this screening effort particularly. But again, this needs to be worked out. Again, private-public partnerships in terms of getting the electronic medical records to both perhaps be for clients, women, to use in history, and of course you've got privacy issues and all that kind of stuff that you have to pay attention to, but also drop-downs for providers to use in doing this kind of screening, some helpful things that would make them feel a little bit more comfortable. There's other divisions of DHHS, especially within HRSA, maternal child, which contains Healthy Start, that these are natural places that routine screening will be rolled out to. HIV/AIDS clinics, STI clinics, well child visits. The whole VA system is an area, as well as the Department of Defense, in terms of providing health care to women, where these initiatives will also take place. I mentioned the IRIS study, Nancy Glass's innovative online intervention, and the provider drop-down aids. So, you know, as my kids and grandkids say, Grandma, there should be an app for that. And there's also notions, a lot of our providers, like our nurse practitioners, have handhelds that they might be able to use, like in a pediatric setting, to give to a mom that she could be assessed for domestic violence that's happening to her, so that the child would not have to hear mom be asked about this. But then you've got issues with how do you link, what kind of a medical record do you have? You don't want to put it on the child's medical record, because then it'll be there if the partner should ever get access to the medical record. So there's a lot of things that need to be worked out, but this brilliant room could be working on doing some of that. And so we did the research to support this. A lot of the people in this room have done really important research that supported the IOM recommendations, and now we need to do the research to implement it. Thank you. And our any questions to take for a minute or two before we start our panel? Yes, ma'am. Yes. I can. Nancy, you want to send her a note?
Yeah, we have an demonstration website for people like to see it, so I can give you that demonstration website. You can log in and just go through it.
So, do you want to? How we going to get it? Send it to Michelle Decker.
Yeah, Michelle, we have a list of all the pending, right? Mm-hmm. We do. Okay, so I can send it out, and you just have to put your name in, and we'll approve you to go in. So don't everybody do it at one time.
Yeah, Mahu is in charge. Yes, ma'am.
My chance to be the idol, the Hopkins idol or something. I was so confused when I first read about the recommendations because the way they're written, they seem to be more about who's paying for this.
They are.
So if there's no cost sharing, is that also a disincentive for doctors to do it, or for facilities to do it, or for new plans to do it? Or is it a requirement that they do it and they just can't charge for it?
It's a requirement that they do it. That's the way it's to be rolled out, and they just can't charge for it. So in other words, that well woman visit, I mean, the way people are envisioning it, it would definitely be part of that. And that's probably the first way that it would go. So if you have insurance under the Affordable Health Care Act, then you can make an appointment for a well woman visit, and I think they're up to, somebody help me, is it once a year?
It's at least once a year.
Thank you.
As many times as needs to happen in order to get all of the preventive services.
Right.
That are recommended.
Right.
Who was charging for it anyway? I don't know. Were people charging for this? I don't know.
Not usually, unless there was, copay kind of things going on.
Thank you.
Right. But it would be expanded to like Medicaid patients who don't always have well woman care visits per se, not outlined like that where you can get all that, the screening kind of things. So, and it's sort of like a beginning that as more and more of our health insurance plans go under the Affordable Health Care Act, that it will become, and the idea is that it will become standard of care. Yeah, and it is about who will pay, but it's that no matter what health care plan you have a well woman visit, and it will screen for those other things as well as domestic violence. Yes?
My understanding is that it's really a mandate from the insurance companies.
Yes, it
and
is.
That, right, and that it's actually, and that the patients have no cost sharing, so they can't have
Right.
to pay a copay.
Right.
But providers will get reimbursed, and there certainly are
Oh,
billing
yeah, right,
codes.
yeah.
There are billing codes associated with, annual preventive care, and even if someone came in just for a 15-minute visit and got
Yeah.
screened, there's screening and counseling codes. So all those should be reimbursed. But providers, do take a hit for counseling visits because they are reimbursed at very low rates, but there is, a mechanism for it.
Yeah, thank you. Thank you. I wasn't clear about that. Yes. All right. So the first panelist, and I believe, Dr. Sharps is here. So why don't I introduce all of you, and you can come down and then just get up, and I don't have to pop up in between because that would be boring. Our first panelist is Liz Miller, who is a physician with a PhD, one of those rare types. who's been doing wonderful research in this area for a very long time from Children's Hospital of Pittsburgh and University of Pittsburgh School of Medicine. Our next panelist is Bridget McCaw, who is the medical director. She's also MD, MPH. You've got the letters down there. Who is medical director at Kaiser Permanente. Wendy Lane, who's at the University of Maryland School of Medicine. And Dr. Phyllis Sharps, PhD RN, who is from Johns Hopkins University School of Nursing. So we're going to put up the...
Well, yeah, I'm trying to...
Okay, yes.